Well, a very good day to all of you who are just, oh, there seems to be a bit of an echo. Has that gone away now? Yeah. A very good day to all of you for our webinar this month. And I am Ashish Chandra. I am hosting this from a hotel room in Thailand, where I'm on holiday, and it's 8 o'clock in the evening. And I'm very, very pleased to welcome Dr. Amy Lee to deliver the webinar today, which is entitled Role of the Core Biopsy, Friend or Foe. Dr. Amy Lee completed her residency in Anatomic Pathology and fellowship in Cytopathology at Stanford University Medical Center. She's currently an Associate Professor of Pathology at Harvard Medical School and practices at the Mass General Hospital. In addition to cytopathology, she has expertise in breast and pulmonary surgical pathology. She's provided training and education in palpation as well as ultrasound-guided FNA techniques for many years, including authoring a chapter for Dr. Cibas' Cytology textbook. And so without any further ado, I would also just like to mention that Dr. Lee is a co-author in the upcoming WHO book on breast cytopathology and has published extensively in breast, pulmonary, and lymph node cytology. She currently leads the Patient Pathologist Consultation Program at MGH, and I cannot imagine a better presenter and speaker for today's topic, which is the role of core biopsy, friend or foe. Over to you, Amy.
Thank you so much, Dr. Chandra. Welcome, everyone. So today we'll be discussing the role of core biopsy. And in this talk, we're going to review the utilization patterns in 3 organs where both cytology, FNA, and core biopsy may be used for diagnosis and clinical management of patients. So namely, we're going to cover breast, lymph node, and pulmonary sites. And at the end, I hope that you will understand the specific considerations and the complementary roles for these different types of small volume biopsies that are used in these organs. And we're also going to very briefly at the end discuss and touch on the workflow and some logistical issues involved when you're diagnosing and then reporting concurrent small biopsies in routine practice. So the purposes of obtaining small biopsies are several. Primarily, they're used to diagnose disease and clinically manage or triage patients. But also they're performed to retrieve tissue for ancillary studies in order to subtype the lesion and to select therapy. There is also a role for monitoring the response to therapy if you don't want to completely resect a tumor or are unable to. And finally, of course, there's the research function where sometimes you have to obtain additional tissue in order to enroll a patient in a clinical trial. So first, let's define core biopsy and fine needle aspiration biopsy. Core biopsy has traditionally been defined as using a needle diameter larger than 22 gauge, and this can be performed under ultrasound, CT, MRI guidance, or it can be done by palpation, especially if the lesion is pretty superficial. When you obtain tissue, the tissue is typically intact, and therefore tissue architecture is readily appreciable. Fine needle aspiration biopsies, on the other hand, usually use a needle diameter 22 gauge or smaller. This may also be done under image guidance or by palpation. And the sample you receive tends to be very fragmented. And when you make smears using this technique, in fact, you do want to create a cellular monolayer on the slide. In recent years, as needle technology has improved, there have been creation of very thin needles, typically around 20 or 21 gauge, that generate small friable tissue fragments with some degree of preserved architecture, but generally very disrupted. And these have been called cell block compatible biopsies in the literature. So first, we're going to consider the utility of core needle biopsy and FNA in the diagnosis of breast lesions. And the advantages of using breast FNA are that they are diagnostically accurate, especially if the operator is experienced in retrieving tissue. They're minimally invasive, as we know, with very few complications. It's pretty fast, it's definitely cheaper in the United States by our reimbursement rates, and FNA costs reimburses about a third of what a core biopsy with clip placement would. And with this technique, you can also prevent a lot of benign lesions from going on to larger biopsies or surgical excisions. They're also able to procure tissue that's amenable to some biomarker testing. The drawbacks of using breast FNA are that it's less reliable if an operator lacks experience. There is a higher non-diagnostic rate because you do generate more paucicellular specimens than a core needle. The grading is not so reliable than on FNA, and it's much more reliable on core. And finally, one of the things that many people say is that FNA cannot distinguish in situ from invasive carcinoma morphologically. While that is true, when you combine the FNA finding with the clinical radiologic findings, this actually can be overcome. So in the setting of a palpable mass, if you obtain malignant cells by FNA, more than 98% of the time, this is an invasive cancer. So as long as you have a clinical finding of palpable mass, you actually can diagnose an invasive carcinoma on FNA. And I want to point out that core biopsy is not perfect either. Up to 20% of in situ diagnoses on core biopsy are upgraded to invasion on excision. And then finally, biomarker testing is definitely preferred to be done on intact tissue, and we'll review some of these scenarios coming up. So Britt Marie Young, currently at UCSF, over 20 years ago, performed this really nice study, and it effectively showed the impact of receiving formal training and how having that formal training in performing an FNA on the breast is associated with high diagnostic accuracy. So what is formal training? Formal training was defined as having done at least 150 FNA under direct supervision of someone experienced, receiving feedback in real time about their technique, doing rows on the specimens and getting feedback on that way. Or you could also qualify as having had formal training if you perform more than 100 FNAs per year in practice. So she found that physicians with no formal training did not sample the cancer in 25% of cases, meaning the needle did not even retrieve any tumor cells. So a complete sampling miss, and 30% of benign lesions went on to unnecessary surgery. In contrast, physicians who did have formal training in FNA of breast, they quote unquote missed one of the cancers on FNA, but actually this was an interpretive error because there were tumor cells on the slide and not a sampling error. So this was just a misinterpretation of the material. Essentially, the sensitivity of picking up cancers in the formal training was 100%. And only 8% of benign lesions went on to unnecessary surgery. And overall, these physicians with formal training produced smears that were much more cellular and had a much lower non-diagnostic rate. Other studies have also found breast FNA to have a high diagnostic accuracy. In this study, for example, of over 1,600 breast FNA, sensitivity and specificity of breast FNA were both greater than 90%, and there were no false positives. And the diagnostic accuracy of breast FNA is reflected in the risk of malignancy assessments when we evaluate breast FNA performance using diagnostic categories for reporting set up by the WHO Yokohama system. In aggregate, across multiple studies performed internationally, The suspicious for malignancy and malignant categories have extremely high risk of malignancies, whereas the benign and atypical categories have appropriately low risks of malignancy. So this breast FNA diagnostic category is a part of what drives clinical management, and it is one part of the triple test. The triple test is a combination of the cytologic findings, the radiologic characteristics, and the clinical impression of a patient's breast lesion. So if you have a benign triplet, the patient can be followed clinically. Patients with a malignant triplet can be referred for additional consultation and treatment. And if you're getting a mixed triplet, that is, you're getting mixed messages, one might be benign, one might be malignant, then the patient should be referred for more workup, including the possibility of additional tissue sampling. One important element of breast FNA is the ability to provide a rapid on-site evaluation, where at least a portion of the sampled material is reviewed while the patient is still in clinic. So this supports multiple agendas. One, the pathologist can check for adequacy of the sample for diagnosis, and so avoid a scenario where the patient has to be brought back for additional sampling. Two, the pathologist can identify whether additional sampling would be helpful to obtain material for ancillary studies, such as creation of a cell block, in anticipation for performing immunostaining, or sending material to microbiology. And third, the pathologist or another clinical care team member can provide a preliminary diagnosis to the patient to alleviate their anxiety. This point is sometimes not well appreciated by some folks in healthcare, but patients with breast lesions experience a tremendous amount of anxiety while awaiting diagnosis of their breast lesions. So these are some characteristics and quotes from patients who have been studied about their anxiety while waiting for a breast biopsy procedure or waiting for the diagnosis. And the waiting itself can be experienced as a form of trauma. Patients have noted that undergoing evaluation for breast abnormality is emotionally distressing regardless of what the final diagnosis is. The worst part was waiting in the vast majority of patients surveyed, and the pre-diagnosis period is actually the most stressful. So a lot of patients feel like they're kind of having an out-of-body experience where they're just suspended from their normal lives, and having had prior biopsies does not make it easier to handle this type of stress. And this waiting stress for a breast biopsy is quantifiably more stressful than waiting for a much more invasive surgery or riskier intervention for a known cancer. So it's really the not knowing that drives a lot of this anxiety. So providing that Rose diagnosis can really alleviate a lot of patient stress. And that is what is possible with FNA and not with core. And in addition to alleviating anxiety sooner with FNA Rose, we are also able to provide patients diagnoses sooner than core biopsies. So this is one study that examined the timeliness of care for palpable breast lesions, and it found that the wait time to diagnosis was 8 to 12 days faster than patients referred to core biopsy. A lot of FNA biopsies in this study occurred the same day that the patient presented for care. In addition, the wait time to treatment for breast cancers, both excision or neoadjuvant chemo, were similar for both groups, whether you had an FNA or core biopsy. So going the FNA route does not delay treatment. This paper from France evaluated the performance of breast FNA in a one-stop breast clinic and found FNA to be highly accurate. So in addition, the proportion of non-diagnostic specimens was lower, the diagnostic turnaround time was lower, And many patients were offered a same-day core needle biopsy when their FNA showed something worrisome. So this really recapitulates all of the issues we've just touched on and supports that a multidisciplinary setup like this can be really efficient and accurate and can reduce patient anxiety as well. So although FNA is known to can significantly improve the experience of patients with breast masses, we know that core needle biopsy is frequently preferred over FNA, and part of this is likely related to the need for assessing breast cancer biomarkers. So can FNA samples be used to assess breast cancer biomarkers? Well, the answer is yes for ER, PR, and HER2, our 3 standard receptor panel biomarkers. And we use these to characterize tumor types, and it drives clinical decision-making for selecting therapies. And this one study showed that FNA cell blocks, there were more than 100 in this sample, had an extremely high accuracy for ER, PR, and HER2 evaluation, including by FISH, which was performed on cell blocks in this particular paper. And other studies have shown that HER2 can also be evaluated on cytologic smear slides successfully, as shown in this paper, where they just smeared and then performed HER2 IHC on the slide itself. Ki-67 has also been successfully evaluated on cell blocks and cytologic smears. Ki-67 is a nuclear protein related to cell proliferation and is showing some utility in determining breast cancer subtyping. So previously, the St. Gallen International Expert Consensus suggested a cutoff of 14% and then later revised it to 20%. So there's a little bit of uncertainty what the actual cutoff is, but it is known to be, Ki-67 is known to be an important predictor, and it can also predict benefit from certain therapies like a taxane. So, but we do have some problems with this biomarker. Studies have shown that Ki-67 scores are systematically higher on core biopsy than in resection specimens. And because there are these inconsistencies and poor reproducibility in evaluating Ki-67, it's not surprising that there's no currently really well-accepted international consensus regarding the optimal detection method or the cutoff point for Ki-67. In our laboratory, I have to say that we only very rarely get asked to assess Ki-67 in breast cancers, but certainly it is done, and it is possible to do so on FNA samples. There are now a couple of newer biomarkers. One of these is PD-L1, which when positively expressed can render a patient eligible to receive specific targeted therapies like pembrolizumab. PD-L1 is assessed by reporting a combined positive score, which is calculated using this formula, a number of tumor cells staining with PD-L1, but also the number of lymphocytes and macrophages in its vicinity that are positive. That's in the numerator. You divide that by the total number of viable tumor cells and multiply by 100. So the maximum score you can get is not 100, but once you hit 100, anything above is just considered very positive. So lymphocytes and macrophages can be intratumoral, meaning within the epithelial nests, or it can be peritumoral stroma associated. So it really needs to have an intact architecture to be assessed in this combined positive score. And therefore, with the need for architecture, this is going to be primed for core biopsy type of assessment. And FNA is not validated for this biomarker. Another breast cancer biomarker that is emerging is tumor infiltrating lymphocytes, or TILs, and cancer prognosis and response to certain immune checkpoint inhibitor therapies relies on an endogenous host effector T cell in the tumor microenvironment. So these are going to consist of a heterogeneous population of immune cells that can either support or oppose cancer growth. These immune cells, or TILs, can be characterized quantitatively or geographically. So quantitatively, you would assess a number, which we'll get to, and then geographically means that you can either assess the number of immune cells in the epithelial neoplastic cells or in the stroma that is associated with the tumor. So a growing body of evidence supports that the TIL density in the stroma is a robust prognostic and predictive biomarker in breast cancer. So, for example, high levels of stromal TILs in triple-negative breast cancers are associated with a decreased risk of recurrence, decreased risk of death, and they correlate with an increased response to certain therapies. So TILs are quantified either intratumorally or in the tumor-associated stroma. And right now, stromal TILs are preferred, and they're assessed as a percentage. So it's the area of peritumoral stroma occupied by lymphocytes over the area of peritumoral stroma. So again, these lymphocytes, and some people do count macrophages, but technically lymphocytes are the only ones you should be counting. They can be intratumoral or peritumoral stroma associated, and therefore, again, architecture, i.e. core biopsy, really is required. However, an interesting study from Japan showed some promising results, as this group was able to quantify TILs on cytology smears of breast cancers with some degree of accuracy. And this would be an interesting area to explore, maybe something that AI could really help us with. A word of caution about AI models as they're being developed, though. Typically, AI models have to be validated against a reference standard, and that reference standard is often human pathologist interpretation. It's known that TIL calculations suffer from rather significant intra and inter-observer variability in some institutions and settings. So, of note, the US FDA has created a CME course to train pathologists in breast cancer TIL assessment to enhance our accuracy, because as we build AI models, this is such an important point that our reference standard be as clean and accurate as possible. So you can scan this QR code if you're interested and sign up for this course. So core biopsy is much more amenable to all the biomarker testing that occurs in breast cancer evaluation, but we really should not overlook that serious adverse effects and complications do happen more frequently with breast core biopsy than FNA. So for example, one example, this is a case of a breast core biopsy with a 14-gauge needle that led to the patient having a hemothorax. And there was another report in the literature of a woman who received a routine breast core biopsy and then needed a blood transfusion because it turned out she had an undiagnosed von Willebrand's factor. So, lest you think that more modern needle technology has reduced this phenomenon, this is a recent paper from this month that documented clinically significant bleeding in about 1% of patients undergoing core biopsy. So 1%, you may say, is low, but it's 100% if you turn out to be that patient who has a serious complication. So to recap, the strengths of FNA are that in breast, it's diagnostically accurate, minimally invasive, extremely safe, fast and cheap, provides accurate triage, especially if you provide rows and you can reduce patient anxiety with that preliminary information. And you can get the standard ERPR HER2 Ki67 biomarker results. Core biopsy, of course, is a little bit better for getting a higher diagnostic rate. It is also very safe, and the grading is more reliable. It does definitively distinguish invasive versus in situ, although there is a caveat that it may need to be upgraded on excision. It is acceptable for all biomarker testing and essentially is the current gold standard for enrolling patients in clinical trials. So the minimally invasive quality and extreme safety of FNA should not be overlooked. And this point will allow us to pivot to the next discussion area, which is sampling of lymph nodes. So this was a patient who actually came to me. She was a 59-year-old woman with neck adenopathy, multiple enlarged nodes for over a month. And she'd been hit with antibiotics for 2 rounds. There was some reduction in her nodes, and she was really being pushed to surgical excision. So her background was that of a nurse. She was an OBGYN nurse for over 20 years in a large medical center, tertiary care. And she really wished to avoid excision. And she called me to request an FNA. She actually lived more than 1,000 miles away from me, but she wanted to come to me to get an FNA because she felt this was the best path for her. And I convinced her that it was probably easier for her to get an FNA near home. And then she unfortunately went in, and instead of getting the 2.5 centimeter node sampled, the 0.6 centimeter node next to it was sampled. And not surprisingly, it was non-diagnostic. And again, she was sent for excision. And she then underwent a second FNA with a concurrent core biopsy of the larger node. So she's resisting excision. And it was called non-diagnostic necrosis. She was referred to infectious disease. The ID physician with the patient in the clinic reads the pathology report comment section that says necrotic cells positive for CD20, suspicious for lymphoma, which completely changes the trajectory of her healthcare. So she underwent a second core biopsy just to get some non-necrotic areas and diagnosed with DLBCL. She went on to chemotherapy. She avoided surgical excision. Took her 6 months to get a diagnosis, but she is now free of disease after getting chemotherapy. So this patient's clinical team was trying so hard to avoid FNA and core biopsy, really pushing for that surgical excision. And it's not surprising because the NCCN guidelines really discourage the use of small volume biopsies for diagnosing lymphomas. As we can see from the current NCCN guidelines, it explicitly states excisional or incisional biopsy is the preferred method of tissue diagnosis, and explicitly states an FNA is not generally suitable for the initial diagnosis of lymphoma. Neither is core needle biopsy optimal. So there are some caveats. Maybe you could use them, but really there's a strong message that small volume biopsies are not great. And as we know, histologic grading cannot be done on an FNA, and sometimes that's important. They also want to have hematopathology review of all slides, so subspecialty review. Well, as we know, B-cell lymphoma categories encompasses a long list of different entities, and thus many ancillary tests have to be deployed usually to provide a specific actionable WHO diagnosis. And each type of lymphoma can have different requirements when it comes to the tests needed for a definitive diagnosis. So for example, Hodgkin lymphoma needs an expert hematopathologist or cytopathologist to review, and usually FNA is not sufficient. Similarly, though, in CLL, an FNA or core is generally not suitable for diagnosing this entity too, which I found a little bit surprising because sometimes a patient can be very clearly a CLL patient when you have a small volume biopsy that is testing out like a CLL. It flows like CLL. There's peripheral lymphocytosis that also flows like CLL. But even in this very low-hanging fruit type of scenario, CLL, the small volume biopsies are still very much discouraged by the NCCN guidelines. Well, the WHO system for reporting lymph node cytopathology shows that cytopathologists are able to discern the presence of malignancy pretty well. And you can see that the risk of malignancy increases with each diagnostic category towards suspicious and malignant. And However, we know that it's not sufficient just to come up with a malignant diagnosis. We need a specific diagnosis that can drive a plan of action. And so trying to achieve a WHO specific entity is the goal. And trying to discern these various types of lymphoma by morphology is not reliable. I just wanted to, for fun, show this 1999 paper on the real system where these different entities of B-cell lymphomas were described morphologically. And honestly, these all look quite similar to me. And it is not sufficient just to look at cytomorphology to make an initial diagnosis of lymphoma. This is also another area that AI models can eventually likely help us with, but we're not there yet. Other cytologic features that have been probed include follicular tissue fragments that were found in this 2021 paper from Japan. They suggest that finding follicular tissue fragments can help differentiate follicular-based processes, but with these being found in reactive and follicular lymphomas in a very similar frequency, 82% versus 100%, it doesn't seem incredibly helpful to diagnose lymph nodes on their own. So immunophenotyping of lymphoid samples should now be routine. This study was published 2 years after that morphologic paper on the real system. And at that time, incorporating flow into lymphoma diagnosis on cytology was not being performed uniformly. The overall positive rate for diagnosis of lymphoma by flow was 77%, with a false negative rate of 0. And similarly, the positive rate for diagnosing primary lymphoma was 74%. So really, really helpful. Not surprisingly, we all know this by now, but the proportion of subclassifiable lymphoma cases increased from 61% to 77% after you incorporate the results of flow into your cytology diagnosis. And the ability to subclassify a particular lymphoma ranged from 28 to 100%. So really the classification accuracy depends on the type of lymphoma you're trying to classify. And this variable adequacy of flow for diagnosing lymphoma based on type is also something found by other studies, including this more recent paper from 2020. Unsurprisingly, they found that when flow was not adequate for diagnosis, it involved cases of large B-cell lymphoma, including Hodgkin, DLBCL, and other high-grade B-cell lymphomas. Importantly, though, the adequacy of flow was independent of the anatomic site or the FNA biopsy technique. So you could use CT, ultrasound, or endoscopy, and you could achieve a similar rate of adequacy. So small volume biopsies are able to diagnose most lymphomas in both the primary setting and in the recurrent setting. And all of the cases in this particular study were reviewed by a hematopathologist. And of note, none of the NLP Hodgkin lymphoma in this study were diagnosed successfully by either FNA or core biopsy. And this is echoed by a study from Stanford that showed they also had difficulty with diagnosing NLP Hodgkin in the primary setting, but were usually successful in the rule-out recurrence setting. So although you may say that FNA utility is very limited, fortunately, NLP Hodgkin is an indolent and rare disease, so immediate therapy intervention is usually not necessary. So one of the things we really like is multi-institutional studies, and they can be really useful to show the ability of small volume biopsies for diagnosing lymphoma. MGH, where I am, is a member of a multi-institutional group of this sort, and we've been examining small volume biopsies for hematolymphoid diagnosis. And we've published several papers on follicular lymphoma specifically in both the primary and recurrent setting, and looking at its utility for diagnosing histologic transformation of follicular lymphoma. So we found that the average number of biopsies per workup was 1.7 for initial diagnosis, and then 1.1 for transformation, and similarly for recurrence. So the proportion of workups that needed multiple biopsies was highest for patients undergoing initial diagnosis. So that was 59%. And the rate of needing multiple biopsies was much lower in the transformation and recurrence groups at 9 and 15%. So this is not entirely surprising. Initial diagnosis has a higher bar. You need to also provide a grade. And interestingly, the addition of cell block to FNA did not significantly contribute to the diagnostic yield of FNA in the study. So for the purpose of initial diagnosis, a complete WHO diagnosis was reported in only 39% of workups. And this understandably correlates with an increased frequency of multiple biopsies. There is a complete WHO diagnosis in the pathology report available in 62% of those undergoing biopsy to query transformation, and 48% for those undergoing biopsy to query recurrence. But there was a very low rate of multiple biopsies being needed, suggesting that one biopsy may be enough for clinical decision-making in these scenarios. And we also found that some patients only had an FNA when they're going through a workup for transformation, a query transformation. And in those cases where an FNA did not show transformation, the clinician did not pursue a core needle biopsy, and it was more of using FNA to rule out a low likelihood of transformation than it was to pursue a rule-in scenario. So the overall rate of repeat biopsy was quite low in the rule-out transformation and rule-out recurrence cases. And when we look at the cases where transformation was positively diagnosed at the end of a workup, 19% required multiple biopsies. And additional biopsies were more likely to be needed if your workup began with an FNA, with a 36% frequency. If your workup began with a needle core biopsy, only 12% required additional biopsy. When we look at the cases where recurrence was positively identified at the end of a workup, 9% needed multiple biopsies, and again, 20% needed additional sampling if you started the workup with FNA versus only 4% if by needle core biopsy. We also consider the impact of performing concurrent flow cytometry in these cases. And the frequency for sending a sample for flow was relatively high for all three clinical purposes: initial diagnosis, rule-out transformation, and rule-out recurrence. Furthermore, most flow specimens were adequate for analysis across all biopsy types and clinical indications. The highest flow cytometry adequacy rate was observed with FNA, and the lowest adequacy rate was observed in the needle core biopsy group. So there was a similar rate of repeat biopsy across all indications, irrespective of flow, and despite flow being similarly adequate across these biopsy types and indications. And interestingly, the time to diagnosis and the time to treatment was not longer in the FNA group, even with the addition of multiple biopsies subsequent. So the value of being able to perform rows on the FNAs may have something to do with that. And similarly to rows in other organs, this recent study found that rows significantly reduced the non-diagnostic rate for specimens. It reduced it from 20% to 12%, and that this can also be done with telecytology support remotely. The rows finding can, of course, help you triage. Does additional material need to be sent for flow cytometry, microbiology, a cell block? Do you need to also perform a core biopsy? So in conclusion, FNA and core biopsy are both commonly used for lymphoma diagnosis, and they may be concurrently obtained. They are both rapid, safe, and minimally invasive procedures with a generally high accuracy for lymphoma diagnosis. Small biopsies do have a lower diagnostic yield for primary diagnosis. For example, intact architecture is just needed by definition to assign a follicular lymphoma grade. And there is a higher subclassification rate with needle core for initial lymphoma diagnosis. But the difference between FNA and core is much less if the patient has a known lymphoma history and they're coming in for a rule out recurrence question or rule out transformation question. In this scenario, either biopsy type may be sufficient. And although FNA has a reported low complete diagnosis rate for lymphomas, first of all, most FNAs for initial or transformed recurrent cases, they were called at least suspicious for lymphoma in usually more than 80% of the time. And this underscores the clinical value that FNA adds for the ability to screen and triage patients who require further lymphoma evaluation, because most patients who come in with lymphadenopathy do not have lymphoma, they have something else. So FNA and core biopsy really are complementary for different scenarios in lymphoma diagnosis. So now we're going to move on to our last area of discussion, the lung. The majority of lung cancer patients are unresectable at the time of presentation, with most patients already showing spread to either regional lymph nodes or distant sites. However, we still need to stage them appropriately in order to accurately get them their clinical management. And currently, small samples are the preferred method for lung cancer diagnosis, as they are minimally invasive, safe, and we have a long demonstrated track record of success with diagnosing using small biopsies. These small biopsies can be challenging because with limited tissue, a pathologist has to establish the nature of the lesion, subclassify the tumor using a limited panel of IHC, which is needed in up to 30% of cases. For example, a P40 and TTF1 to subtype a non-small cell carcinoma, or performing a Ki67 on a neuroendocrine tumor, because we do not count mitoses on smears. And our goal is to arrive at a specific WHO diagnostic entity. And all the while, we are very interested to preserve and triage tissues for appropriate testing. So we have PD-L1, ALK, ROS, and EGFR immunohistochemistry that can be performed, but also next generation sequencing and solid tumor fusion assays are often performed to further refine a diagnosis. And we're all trying to do this with a limited tissue sample. So how good are we at this? Well, we're pretty good. This multi-center Italian study found that FNA was more than 95% accurate for lung tumor diagnosis. And furthermore, performing rows for pulmonary lesions is safe. You may think it adds a little bit of table time and possibly risk of pneumothorax while you're waiting, but this study found that it was pretty safe. And they did not find rows to be associated with increased complication rates. Furthermore, given that we're doing molecular testing on so many of these samples that are malignant, molecular testing on FNA material may be superior to FFPE samples. And this is something that is known when you preserve material in alcohol, it is a higher quality than running it through formalin fixation. And one of the ways that FNA supports this is when you perform rows, you can rinse your needle into a solution, a medium, and that preserves that high quality nucleic acids for molecular testing. And this is something that would normally just not be morphologically reviewed. Material that is stuck in the needle shaft, you just don't ever see, but it turns out it is very useful for performing ancillary studies. So this is one example of a small cell carcinoma where we see our typical morphologic findings of molding, and we see apoptotic debris, speckled chromatin, crush artifact. And in this case, we had a concurrent core. So this happens quite frequently where you get two types of cytologic and surgical pathology samples. So the IHC in this case supported a small cell carcinoma with chromogranin TTF1 positivity and a Ki67 greater than 99%. But we can do this with cell blocks too. We don't need a core. So this other case is a little more interesting with a 67-year-old man with a 50+ pack year history of smoking. He also came with a history of laryngeal squamous cell carcinoma and urothelial cell carcinoma. So his 7-centimeter hilar mass was FNA'd. It was deposited into thin prep, and you can see these very large nuclei as well as a little smaller nuclei. So the chromatin was a bit speckled. You wonder if some of these have some small nucleoli. The amount of cytoplasm in some of these cells is greater than others. So this is kind of interesting. It does seem to be a high-grade lesion. And on cell block, so there was no core associated with this. Everything was thrown into thin prep, and then a cell block was created from the thin prep material. The cell block contained these similar cells, and RB was preserved. SMARCA4 and SMARCA2 were both lost, and a whole host of, I think, 20 stains were run. They were all negative for all the neuroendocrine markers, including the more recent PAU2F3 and YAP1 markers. Keratin was negative, Claudin-4 was negative. And so this, with just FNA and cell block, we were able to reach a diagnosis of favoring a SMARCA4 deficient undifferentiated tumor. So we can be very successful even if we don't have core biopsy. So in addition to subtyping, though, PD-L1 is a biomarker that has also emerged in lung cancer, and that requires, as we know, intact tissue. And in contrast to PD-L1 evaluation in breast, PD-L1 evaluation in lung cancer uses TPS, not CPS. So TPS is the tumor proportion score, also presented as a percentage, and it's calculated based on the proportion of tumor cells that have PD-L1 membranous staining. So any degree of membranous staining would be considered positive. It can be partial or complete and can be of any intensity. And you multiply this proportion by 100. So therefore, because you don't have any concern about the cells around the tumor cells, this can be performed on a cell block. And we don't need architecture. So cell blocks with limited or no intact architecture can be used, provided you have at least 100 cells present for evaluation. In this example, the tumor is a high expressor of PD-L1, as you can see in the lower right corner, with very strong membranous staining in almost all tumor cells. So with lung tumor patients, frequently patients show up for one biopsy encounter, and then from that encounter, they have multiple samples obtained from multiple sites, and the intersection of cytology and surgical pathology has never been greater. And different institutions have different approaches to handling this combination of cytology and small core needle biopsy specimens that have historically been reviewed by surgical pathologists. There was no dominant approach or consensus found whether these reports should be unified or split based on a survey of ASC members. And these findings indicate that no one has discovered a clearly superior way of managing these specimens in order to minimize confusion and discordance, and how to maximize ancillary testing utilization. So when you split a concurrent sample, concurrent specimens like this, it results in specimens being issued, having diagnoses issued in two different reports. For example, one in cytology would address the FNA smears and cell block, and the histology from SurgPath would look at the cores and transbronchial biopsies. And when you split these FNA and core needle biopsies from each other, they're reviewed by separate pathologists and can cause major discrepancies in diagnosis and result in redundant ancillary studies being performed. So one thing that you can do is to create an integrated combined pathology report for all these concurrently obtained tissues. For example, in this case, reporting the FNA, cell block, and transbronch biopsy all together. And a recent task force of the ASC advocated for a one pathology report issued for each biopsy encounter. And that would integrate the diagnoses for all specimens. And this approach could reduce the discordances between these parts. It can mitigate confusion for clinical colleagues and patients. And when you see all the material together, you can judiciously select the best material for each purpose. So whether you're sending something for molecular or IHC or scanning it for education, you can see the entire case and be selective, picking the right material for the right test and purpose. Furthermore, that would also support avoiding redundant workup and testing, and therefore conserving tissue for molecular. So in conclusion, FNA and core biopsy are complementary diagnostic modalities, and the pros and cons of selecting which biopsy method should be weighed in each scenario. And you should carefully consider the clinical purpose you're trying to achieve, and also acknowledge the skill sets that are available to you in your local practice. And I would suggest that we consider integrating reporting of concurrent FNA and core biopsy findings for the reasons I listed before. So I'm happy to entertain any questions at this time, or just listen to your thoughts on how things are going in your practice.
Great, excellent. Dr. Lee, thank you so much for covering so much breadth and depth of the comparisons between fine needle aspiration and core biopsy and across three major areas. And thank you for the concluding remarks. There are a few questions in the chat box that I would like to read out to you first. And the first of these is, short of clinical and radiological findings, should DCIS be reported on cytology smears, or is it advisable to report them as suggestive of invasive breast carcinoma and advise clinical radiological correlation? Thank you.
Yeah, great question. And I've seen some papers that describe DCIS. For example, sometimes you can see a cribriform pattern emerging on a cytologic smear from a breast, and that could very much suggest a DCIS diagnosis. My practice is to just call it adenocarcinoma. I don't specify whether it's invasive or in situ. So I just say it's adenocarcinoma, and then the clinical features and the radiologic features have to be considered in conjunction with that malignant diagnosis. So really should not have to specify in situ invasive on an FNA report.
Absolutely. Thank you so much. I completely agree. I think you know, the users of the service, the clinicians, should know what to expect from the test that they're requesting. And so it would be really unusual for them to expect the distinction between in situ and invasive disease on any cytology sample. You know, when we report lung adenocarcinomas, even on a sputum sample, for instance, if we're reporting a squamous cell carcinoma, we don't then say, well, this might be in situ or this might be invasive, because that is really just down to the clinical and a radiological correlation that you would just expect the clinician would do anyway. So great, thank you for answering that. The second question here is, what stain do you use for Rose evaluation?
We use different stains depending on which scenario, which setting we're in. So if I am in FNA clinic and I'm performing an FNA on a patient, I will typically use a diff-quick stain on an air-dried smear, but I also do have a toluene blue on hand if for some reason I feel like I would like to also look at the alcohol-fixed stain. And really the purpose of this is because we need to educate our trainees in air-dried material. And the other settings where ROSE is performed, where there's involvement of interventional radiology, they have a habit of providing everything in alcohol fixation. And so to balance that out, I have really focused on giving them DiffQuick in FNA clinic. But, you know, the important thing is that we are used to looking at different methods of preparation. When we have alcohol fixed slides in IR, we stain them using a rapid H&E, and in FNA clinic, we use DiffQuick and toluene blue. And I feel like that gives a nice breadth of training for our residents. So you can mix and match depending on where you're practicing and what resources are present. So I would just suggest that we get very comfortable in looking at different types of samples and different preparation methods.
Lovely, thank you very much. Yes, our practice is very much the same. We tend to use a Romanovsky stain, whether it is DiffQuick, we use Hemocolor. I know some institutions use a rapid MGG. So any sort of variation of that, but also, using toluene blue in specific circumstances, as you said, is really valuable. Thank you. Another question is, can you say more about TIL evaluation in breast cancer? I must say you did actually cover it quite well in your presentation, which, by the way, is recorded. And so if there's any bits that you've missed, you could always just wait for the recording to be uploaded. And then you can listen to some of the things that you may have wanted to. But Amy, is there anything you could do a quick recap on for TIL in breast carcinoma?
Sure. So when we look at TILs and breast cancer with our current understanding of its features and its importance, we're really looking at the lymphocytes, so lymphocytes and plasma cells in the stroma involving a breast cancer. So you don't want to look at a immune cell population far away from the breast cancer. It really needs to be in that tumoral stroma. And it can be a little bit challenging to define what is tumoral stroma, and that's an ongoing area of research. But nonetheless, the idea is that we look only in that stroma associated with the tumor, and we are looking at the density of infiltrating lymphocytes. So it's an area calculation. You're looking at how much of that stroma is occupied by lymphocytes and plasma cells. And so there are some studies that have included macrophages in their study. Some studies have looked at CD3 and CD8 subpopulations, but right now the gold standard per the International Working Group on TILs, led by Roberto Salgado, is that we look at this on H&E with no immunostain. So it's conceivably a really cost-effective, easy to access biomarker for a lot of patients. And right now it is mostly studies that are showing this association between an increased number of TILs and a better prognosis in the triple negative breast cancer subset. There are some other studies looking at the association between TILs and outcome in ER positive tumors, HER2 positive tumors. I think that data is a little bit young and needs to be fleshed out more. But certainly, I feel like this is a very promising biomarker. The St. Gallen and the WHO Blue Book, they both say, they have statements, written statements out in the community that support TIL as a potential, very promising biomarker, but we are just not there yet. It has not been fully incorporated into clinical guidelines at this time.
Thank you so much. I think that really does sort of encapsulate what you had said, and I hope the person who's asking the question has found the answer that they were looking for. Dr. Lee, it is just a minute now to the hour, so thank you so much for a really, well-timed presentation, and for taking all the questions that were coming in. I had some questions, but perhaps they're for another day. And I really thank you for your time. I realize you probably have to get back to work, and so a huge thanks.